In this episode, we continue our discussion of scrotal symptoms with focusing on the symptoms with acute to subacute progression. Again, I cannot emphasize enough on the fact that the very first step to any scrotal symptom is to rule out torsion regarding timing or any other symptoms that you may encounter. Based on that, you have a patient who had come with acute onset scrotal or testicular pain. What is the next step? Physical exam and history to evaluate the 4 cardinal presentations of torsion. If they are negative, that is, all 4 of them are not present, the next step will preferably be a scrotal Doppler ultrasound, as we still need to rule out torsion. However, if you are asked what is one specific finding among the 4 cardinal presentations of torsion that is not present in any other differential diagnosis of acute scrotal symptoms, especially acute scrotal pain, what's the answer? Remember, only in torsion the cremasteric reflex will be absent or impaired, but even in testicular appendigeal torsion, which is different from testicular torsion, as well as the differential diagnosis of acute scrotal symptoms, the cremasteric reflex is usually maintained. Now, what are the major differential diagnoses of acute scrotal pain or acute scrotal symptom, let's call it? After we rule out torsion and trauma, our first 2 rule out that we discussed in previous episode, we need to think about epididymitis, Epididymo-orchitis or orchitis itself, inguinal hernia, and Fournier's gangrene. Remember the Fournier gangrene, the necrotizing soft tissue infection of the perineum. The framework is to rule out torsion first and then do the assessment based on the clinical findings for each one of these 3. So let's start with acute epididymitis and orchitis. What are the risk-based pathophysiology of acute epididymitis? The risk is determined mainly by association to age of the risk factor, and by that I mean we have the cutoff of age for 35 years. For patients younger than 35, usually we are dealing with a type of STI such as chlamydia or gonorrhea as the underlying cause. But if the patient is older than 35 with symptoms of epididymitis, we are usually thinking about bladder outlet obstruction and possibility of coliform bacteria. What are the other factors that this age-specific differentiation would help? One is understanding that, for example, if a patient is older than 35, we are most likely dealing with someone who has complaints of urethritis, most commonly due to E. coli, and also the treatment will be focused on the enterics in that age group. While if we are dealing with a younger patient, we would focus on possibility of parallel symptoms of STI, and again, treatment will focus for the choice of empiric antibiotic on Neisseria and chlamydia. The other relevance is that to bear in mind that these are not rigid age-based differentiation. For example, if a patient older than 35 is engaged in high-risk sexual activities and now has testicular pain, it is possible to be due to STI similar to the one that happens in patients younger than 35. So what are the subjective, historic and objective physical exam findings in epididymitis? That is, in addition to the symptoms of the underlying etiologies based on the age cutoff of 35 that we discussed. The swelling and pain in the epididymal area, where is it exactly? Remember, the location of epididymitis, epididymis itself is posterior superior to the testis. This will come handy when we discuss differentiation of testicular mass from epididymal mass or swelling, such as here, and also some conditions associated with mass that we will cover later on. I want to mention a vignette here. We have a 42-year-old man with unilateral scrotal pain, mild fever, whose scrotal physical exam shows pain and swelling in the posterior superior aspect of the left testicle. He is sexually active with his wife of 15 years in a monogamous relationship. What other symptoms you expect in this patient? The choices are provided several other symptoms. 2 of them are difficult. One is purulent urethral discharge and the other is dysuria and frequency. So remember, again, I said forget about the other choices. These are the 2 challenging choices. The one that talks about the purulent urethral discharge tries to make you think about STD, and the one that mentions dysuria and frequency favors urethritis. So remember, the patient is not having high risk behavior for STIs, and the patient is older than 35. Therefore, we expect this patient who is in a monogamous relationship to have the urethritis by coliform bacteria as the underlying etiology of his epididymitis, and therefore we pick dysuria and frequency as the other possible positive clinical findings in this patient. Now, the next is a very important question, and that is differentiation of epididymitis from torsion. We talked about the fact that we need to perform tests and clinical evaluation to rule out torsion if the patient has some of the risk-related findings. And our evaluation to rule out torsion begins with physical exam to evaluate the cardinal manifestations. On the physical exam, what findings help differentiate torsion from epididymitis? First and foremost, always remember the Prenz sign. What is it? The relief of testicular or scrotal pain by elevation of scrotal contents is referred to as a positive Prenz sign, and it favors diagnosis of epididymitis. Remember, in torsion, the pain does not improve and may even get worsened by elevation of scrotal contents, by testicular elevation. Now, I would like to ask a statistical question here. True or false? Positive Prenz sign is considered a sensitive finding to rule out torsion. That is false. Even though it is absent in torsion, it lacks specificity to confirm the diagnosis of epididymitis. How do we interpret this finding in terms of clinical practice? We still need to rule out torsion if the patient has acute scrotal symptoms. That said, what are the other findings that help differentiate epididymitis from torsion? Remember, epididymitis is more common in older adults because we mentioned torsion is common among the adolescent age, while the most common demographic age group where we have epididymitis are the sexually active young men. Epididymitis has a more gradual onset compared to the torsion. Never forget, one of the cardinal symptoms of torsion is initiation of symptoms within the 24-hour period. Not only Prenz sign is positive in epididymitis, we have also worsening of symptoms with standing in epididymitis. And finally, we have the symptoms associated with the underlying etiology, as we mentioned, either STI or urethritis. Now, moving to assessment and plan for epididymitis. Again, remember, if there is any of the warning signs, we need to first rule out torsion. But if the symptoms together favor possibility of epididymitis, what are the tests to perform? Remember, urine analysis and urine culture, as well as tests for the STIs, including nucleic acid amplification test for chlamydia and gonorrhea. Now, a point I need to add here about the specificity of our workup and treatment planning. I initiated this entire episode of scrotal pain in young men with the need to rule out torsion first and foremost. Now, if you have a patient who does not seem to have the symptoms associated with torsion, but seem to have most of the symptoms associated with epididymitis, what would be your very next step in the assessment? In such a patient, for example, when the testicle itself is not painful, Prent sound is positive, and the superior posterior part of the testicle is painful, and possibly the patient has risk factors, we have such a low likelihood of torsion and high likelihood of epididymitis that we initiate with workup for epididymitis, okay? So my emphasis was to just make sure that we have very high sensitivity, at least in clinical practice. But when it comes to standardized tests, you may want to be more diplomatic and just see if the weight of symptoms are really in favor of epididymitis, and then you begin working up for that diagnosis. The second point is regarding nucleic acid amplification test or culture of the swab of the urethral discharge. These two tests are for the STIs, right? So if the patient again does not seem to have the symptoms or demographic risk factors associated with STIs, you don't need to necessarily go through such molecular tests as NAAT, and you will be good just to perform the midstream urine analysis with urine culture for coliform bacteria. Now, regarding the treatment, what are the points to consider? Well, we need to figure out if the patient belongs to category of coliform risk factor. Those are the older than 35, low risk sexual behaviors, mainly urethritis symptoms, and we treat them empirically with the antibiotics that covers the coliforms, including fluoroquinolones, levofloxacin. Or if the patient belongs to the group of the high risk for sexual transmitted infection as the etiology, therefore we cover Neisseria with ceftriaxone and chlamydia with azithromycin or doxycycline. Now, there are certain considerations that we need to keep in mind, and that's mainly the conditions in which we need to cover coliform and the antibiotic for the epididymitis in children. So what are the indications in which we need to cover the coliform bacteria? One category is children, of course, because we are not concerned with sexual transmitted infections, at least as of right now. I don't know what will be the upcoming year's standards, but as of right now, as similar to the entire history of mankind, that is not top of the list of differentials, unless if we are concerned with an abuse case, which is not the discussion in this episode. And the other group is, of course, the ones that we mentioned, the ones older than 35 years. These are the two main groups, and the third group that we need to cover coliforms, including E. coli, are the male having sex with men, the male homosexuals. In these three categories, we need to have a coverage for E. coli as the empiric treatment. Again, therefore, we provide levofloxacin if they are not children. However, if they are children, what is the consideration for antibiotic coverage? We don't tend to use fluoroquinolones for children, therefore we use the alternative coverages for E. coli, and that is Bactrim. Now, another important question are what are the precise indications in children to cover the coliform? Remember, if a child has the findings of epididymitis, especially with pyuria in urine analysis, if the culture is positive, which will not be the empiric anymore, or if the patient, the boy, has genitourinary abnormalities with findings of epididymitis. In these conditions, given the high likelihood of a UTI, we need to cover the antibiotics covering coliform. The final point about the men's having sex with men, what antibiotic coverage is needed. We need to not only cover the antibiotics for STI, and that is ceftriaxone for gonorrhea and azithromycin single dose or doxycycline 7-day course for the chlamydia, but we also need to add an antibiotic for the coliform coverage, and that is for the E. coli and other possible culprit pathogens, and therefore we need to add fluoroquinolones as well. Now, I mentioned that we have a couple other differentials for acute or subacute testicular symptoms, including inguinal hernia and Fournier's gangrene. So let's just discuss the ways we can differentiate them, beginning with this addenda to Epididymo-orchitis, and that is mumps orchitis. What are the findings that could help differentiate mumps orchitis from epididymitis? We have usually an unvaccinated child, and usually in the setting of a possible outbreak. What physical exam findings support orchitis as opposed to epididymitis in general? Remember, orchitis means inflammation of testis, while epididymitis means inflammation of epididymis. Therefore, in orchitis, we have the testicular pain and tenderness, not the area that is tested as this bulge on the posterior superior aspect, distinct from the testicle. The other, of course, is the findings associated with mumps. In addition to being unvaccinated during the setting of an outbreak, we may have parotid gland swelling. What is the basis for diagnosis and management? Well, we mainly say the diagnosis of mumps is based on these clinical findings, though we may perform serologic tests if diagnosis is not clear. The management is usually supportive. We can consider NSAIDs for testicular pain or scrotal support, such as elevation of scrotum and avoiding the exercises or activities that may irritate the scrotum. Just very briefly, what findings supports the possible diagnosis of inguinal hernia? In addition to the physical exam and Valsalva maneuver, we need to still rule out what? We need to still rule out torsion. And therefore, what is the very next step in the workup after physical exam for a patient with possibility of diagnosis of inguinal hernia? That's ultrasound. Now, what is the ultrasound finding in the inguinal hernia? While in the diagnosis of torsion, we mentioned absence of blood flow as well as presence of possible heterogeneous echogenicities indicating of possible necrosis. For torsion, in the case of inguinal hernia, we have simply intestinal lumen, or you may be provided the descriptive term, and that's the air-filled contents that shouts at us this is some intestinal luminal component in the scrotum. Management is surgical repair. Now, why the differentiation of torsion from inguinal hernia is important? Not only because of the fact that we need to always rule out torsion in any acute scrotal pain, but because of the fact that same risk factors could apply, especially the type of maneuvers and exertional activities associated with inguinal herniation could also be associated with torsion, including heavy weightlifting, for example. If you hear the word heavy weightlifting, don't pick immediately inguinal hernia. It could be also causing torsion, and therefore we need to follow again our algorithm, assessing initially, first and foremost, the cardinal symptoms of torsion. And finally, we have this necrotizing fasciitis of the perineal region, the Fournier's gangrene. What are the findings on it? We have the findings of necrotizing soft tissue infection, including severe pain, pain out of proportion to physical exam finding, possibility of bulla formation with crepitation, and then patient gradually deteriorates with findings of systemic inflammatory response syndrome and possibility of septic shock. However, the most important hint, in addition to these progression of the symptoms, is the presence of risk factors in one way or other associated with suppressed immune system, including elderly and diabetic or patients with immunodeficiencies. What's the management? Resuscitation, early extensive surgical debridement, and immediate onset of broad spectrum IV antibiotics covering the culprit organisms. This finishes our discussion of scrotal pain with acute to subacute onset. Again, rule out torsion, see if we have symptoms in favor of either epididymitis or inguinal hernia or Fournier's gangrene, and manage accordingly.